Okay, moving on to part 2 of chapter 38, dealing with geriatrics. We're continuing with some system pathophysiology and assessment management of the geriatric patients, and we're well into the neurology section in the elderly patient, and we're talking just briefly about Alzheimer's disease. Alzheimer's disease is the most common cause of dementia in the elderly. Signs and symptoms include gradual memory loss, decline in ability to perform daily tasks, disorientation, judgment impairment, and then severe personality changes. There is no cure for Alzheimer's disease once the diagnosis is made. There are medications that people may take that may lessen the symptoms and slow the progression down. It is believed that the cause of Alzheimer's is amyloid plaques that cling and attach themselves to the myelin sheath of the brain, causing a disruption in brain signals. But it can be early onset, diagnosed in the 40s and 50s, and late onset, where they're well into their geriatric age before any of these signs and symptoms show up. Parkinson's disease is a damage or degeneration of the dopamine-producing nerve cells in the basal ganglia portion of the brain. Signs of Parkinson's notably are tremors, bradykiniasias, postural instability, rigidity of muscles. It results in low levels of dopamine, and much like Alzheimer's, there is no cure for Parkinson's once the diagnosis is made, and can be treated and lessen the symptoms and slow the progression down by administering medications that resemble dopamine. When we're talking about endocrinology in the elderly, we know that as we age, all our organs don't function near as well as they have in the past, and your pancreas is no different. Glucose metabolism is often difficult in the geriatric patient. Thyroid function is also affected as we age. And remember, the thyroid gland is responsible for things like metabolism. The parathyroid gland responsible for things like storing and releasing vitamin C. And certainly when you have thyroid gland issues, it's going to affect your metabolism. And then if your pancreas isn't working correctly and secreting healthy insulin, managing blood sugar levels may be a challenge. This is where in the past, typically type 2 adult onset diabetes occurred as the insulin becomes less and less effective that's being secreted from the pancreas. However, we know that over 50% of the children diagnosed with diabetes today are type 2 diabetes related specifically to obesity. Diabetes is the most common endocrine emergency that you're going to see in any patient, to include the elder patient. Diabetes is the number one cause of blindness, the number one cause of limb amputation, non-traumatic limb amputation, hearing loss. Diabetes also increases your risk of injury to the blood vessels and accelerates coronary artery disease, increases your risk of stroke, increases your risk of kidney failure, increases your risk of limb ischemia, which leads to amputation of the limb, and again is the number one cause of blindness in the United States. Your risk of death is twice as high when you have diabetes. Your risk of heart disease and stroke is 2 to 4 times as high, and you add with that other risk factors to include the older you get, if you have a family history of diabetes, if you are obese, certainly those risk factors increase the chance of getting a diabetes. The leading risk factors for type 2 diabetes is what we just talked about. The older you get, if you've got a history of diabetes that runs in the family, if you're morbidly obese, excuse me, the treatment goals is to control your glucose. And that may be done through a variety of methods. If your blood sugars are low, as a paramedic, we can give IV dextrose. It's arguable whether we should be giving 50% or 25% or 10%, but we just can't come off that 50% dextrose dose. If you can't start an IV or an IO to give IV dextrose for low blood sugars, you certainly can give IM glucagon. Glucagon is a hormone that works by it causes the liver to release glycogen and convert it into glucose. As long as you have sugar stores in your liver, then glucagon may help you raise the blood sugar. Also with diabetes, we know that high blood sugars are going to lead to dehydration, and so the administration of IV fluids would be appropriate in a dehydrated patient with a high blood sugar. Thyroid disease is just going to present with a lot of vague symptoms. You have hyperthyroidism, where everything's going to be up. The patient is often thin, and they're quite hyperactive. They may develop the bulging eyes, where hypothyroidism, their metabolism is really slow, so they often to be heavier set. Those sort of things. And when you have thyroid disease, the pre-hospital treatment is aimed at symptom control and transport. So if they're experiencing a thyroid storm, for an example, where everything is up to include their heart rates, if they have really rapid uncontrolled atrial fib that is leading to an ambulance call, you would treat that as rapid uncontrolled atrial fib with cardizem and maybe synchronized cardioversion, rather than adjusting the amount of circulating thyroid hormone. Gastroenterology in the elderly, again, because of improper diets, not eating adequate amounts or enough, can lead to malnutrition. Gastric reflux disease is common in the elderly. Management for that is difficult. Elder patients also end up with, at times, difficulty with swallowing because of decrease in motility of the esophagus and structural problems with the throat and the esophagus as they age. As a result, foreign body obstruction of the esophagus may be common. They may have trouble getting it to pass down into their stomach. We've often treated patients in the emergency department with, a real heavy solution of meat tenderizer, particularly if it's meat, that may help soften up the obstruction and help it pass. Because of their perception of pain is different, or because their perception of pain is different, they may not have abdominal pain, even though they may have serious abdominal problems like a bowel obstruction, intussusception of the bowel. They may have all these. They can even have a ruptured appendix and not really have any severe abdominal pain with it. As with all patients, once you've determined that the cause of their problem is in their belly, you may not be able to diagnose exactly what it is, but certainly evacuating them to a physician or a surgeon, more likely they'd benefit from a surgeon, and you may have to give IV fluids if their pressures are low. GI bleeds, they can increase as a result of ulcer disease. Diverticuli will bleed. Bowel ischemia may contribute to an increased risk of a GI bleed. And patients who bleed internally from the gastrointestinal tract or into the gastrointestinal tract may have all the classic signs or symptoms of shock, but you can't see any bleeding. They may be short of breath, pale, cool, clammy, weak. If they do have blood in their GI tract, it often leads to diarrhea. So if they're complaining of diarrhea, you want to ask them, is it any bright red blood, or is it a dark black tarry foul stool, which is called melena, and that would certainly indicate blood in their stool. Treat the shock. If they're tachycardic and hypotensive, you treat it as hypovolemic shock. You give them fluid boluses, but not unless their blood pressures are less than 90. Beta blockers may mask hypovolemia in elder patients with GI bleeds. Remember, the beta blockers slow down the heart rate. So if they're on beta blockers, and perhaps a beta blocker and a calcium channel blocker, they may not get tachycardic with their slow, insidious blood loss through a GI bleed. GI bleeds can be significant where they're bleeding quite heavily, in which case you might see them throwing up bright red blood, or they may pass bright red blood in their stool. In any event, you may want to establish 2 large bore IVs and give some fluid administration to maintain pressures above 90. Remember that active, frank red blood bleeding coming out of either end is life-threatening. Bowel obstruction is also something that we'll see in elder patients, particularly those with histories of prior abdominal surgery, if they've got an incarcerated hernia. Those are all increased risk factors for bowel obstruction. Bilious emesis is indicative until proven otherwise. So if they're throwing up bile, then that's a good indicator of a bowel obstruction. With incarcerated hernias. Remember, a hernia is a weakened area of the abdominal wall, or in male in the scrotum, and they can herniate a portion of their bowel into those areas, and the bowels may become twisted and obstructed and lead to a bowel obstruction. Signs and symptoms include vomiting and intermittent abdominal pain. Remember that the response to pain is going to be slightly different, but if you keep shoving stuff in and it won't pass, eventually that stuff is just going to fester inside of there and make you really sick and make you throw up. Again, if they're you got an elder patient with uncontrollable vomiting to the point where they're just bringing up bile or even stool, then you know that they have a bowel obstruction. Antiemetics in elder patients will cause drowsiness, will cause akathisia and dystonic reactions. Some psychological disorders in the elderly patient. Depression is common, very common, especially as they get older. Oftentimes it is unrecognized. It goes untreated in the elder patient. It may not appear with the usual symptoms. They may just have some very vague complaints, or they may be agitated or extremely anxious. At a particular age, I suppose you start to think about things like how much longer do I have on the earth? And especially when you see people that you've grown up with, people that you've been friends with, relatives, dying off as you get older, those certainly have to be things that you might think about, which may lead to depression. So depression, just dealing with end-of-life issues, is a very common problem among the elderly. Risk factors include those who have chronic illness, those who are experiencing the financial pressures, those with loss of physical mobility, if again they're bereaving the death of a loved one, or if they have decreased cognitive function like dementia. Warning signs include frequent non-urgent EMS calls to the home of an elderly patient, frequent ED or physician office visits, Physical findings don't match the severity of the complaint. They may have poor hygiene, poor housekeeping, may have, appear to have loss of any sort of enjoyment, and no real social support network. Treatment would be counseling and then medications and then establishment of a social network so that they can get out and meet people and feel better that way. Suicide is at a higher rate in elder patients compared to any other age groups, and men, of course, more frequently than women, and men are far more successful than women, and men are far more violent, often using a weapon as a form of suicide. So when you have an elder patient who is saying that they want to end their lives and that they just don't want to live anymore, certainly take those complaints as seriously. Stay with the patient at all times. Be on like a suicide watch, and provide them the empathy and time that they need to work through this unhealthy thought. Risk factors for suicide include alcohol abuse and drug or alcohol dependence in the elder patient, death of someone close, if they are chronically depressed, if they feel isolated, if they feel they've lost their purpose in life, and sickness, a chronic medical condition. Integumentary changes with age, and here we're talking about the skin. Skin undergoes general atrophy during aging. It becomes thinner, it loses its strength. As a result, skin tears are more common, and they're harder to heal. Skin changes put the elder patient at risk for skin tumors, secondary bacterial infections, because the skin no longer acts as a good barrier to infection. Fungal and viral infections as well. Again, I had mentioned skin tears, they're at risk of those, and then even loss of protection from minor trauma. Glands within the skin have decreased function as well, so they may lose their ability to sweat, and that may cause them to become hyperthermic. Heat dissipation by evaporation of sweat is our most effective way of getting rid of body heat, and if we're not producing as much sweat or we don't produce as much sweat, we have a less effective means to get rid of body heat, like convection or radiation or those methods, which aren't near as effective as evaporation of sweat. So the elder patient may be hyperthermic. Look for underlying systemic illness as well in elder patients. Get a good set of vital signs. Ask them if the blood pressure is quite low or quite high, if that's normal for them, or if the pulse is quite slow or quite rapid, if that's normal for them. You want to assess them for pressure sores, and we'll talk briefly about pressure sores, cellulitis in the lower legs, an inflammation of the cells, or an inflammation of the cells in the legs, where the legs become swollen, red, and later can become black and gangrenous. Septic shock from an underlying infection, and they don't always have to have a high temp with sepsis. Pressure ulcers are common in immobile elderly patients. Remember that their skin is thin and less vascular and puts them at a greater risk factor that if they lie on the skin for a long period of time or constant pressure on a bony area, they don't get good circulation to the skin. It starts to break down, and they can develop pressure sores. This is actually something that's commonly been seen in long spine board immobilization, and one of the reasons that we're advocating not to use long spine boards because of the development of pressure ulcers in elder patients who are strapped to those boards for a couple hours at a time. Frequent movement is the best prevention for pressure sores. Turning them Q4 every 4 hours or every 2 hours may prevent pressure sores. Of course, because the pressure sores open the skin up to the environment, those sores are prone to infection. They can cause sepsis and lead to death of the patient. Pressure ulcers, the treatment, proper nutrition, local wound care, surgical debridement. Look to see if they have signs of systemic illness like sepsis as a result of their pressure sore. And a pressure sore could be a sign or a symptom of possible dependent adult abuse or neglect. Musculoskeletal changes with age. The skeletal system becomes more brittle, more susceptible to injury. Osteoporosis worsens bone loss. They become, again, brittle, thinner. We should try to immobilize all suspected fractures. And if these patients are in a great deal of pain and their vital signs are stable, there's nothing that says that we can't administer medications for pain control. Their mobility is decreased because of loss of muscle mass, arthritis, normal balance problems, and medications may cause problems with their balance as well. So elderly patients are at risk, greater risk of fracture. Even minor trauma can cause significant fractures. They're often broken bones without a gross deformity, and as a result may be a little difficult to identify. But in any sort of injury, you should sustain a high suspicion for a potential fracture. And if they're in a great deal of pain, then again, pain management is appropriate. Osteoarthritis is a disease process that affects primarily the joints. You'll see osteoarthritis in the knees, the hips, the spine, the hands, particularly the fingers, where they get all knotted up and pulled together with large, the knuckles become quite enlarged, the hands become quite deformed, that sort of thing. Consider other diseases as the cause of arthritic or extremity pain, to include gout, which is typically in the big toe, or septic arthritis. Use care when transporting an elderly patient with joint pain. Put them in whatever position is most comfortable. Determine whether or not they've had any recent trauma or a fall. Splint anything you suspect may be fractured, and then ask them about the need for analgesia for pain. Osteoporosis is the most common disease in the United States. It's loss of bone mass and normal structure. 50% of postmenopausal women have low bone density. Risk factors include age, family history, smoking, corticosteroid use. Protective factors include a high body mass index, estrogen use, exercise, and alcohol use. Fractures in the musculoskeletal system may be obvious or may be very difficult to detect. CMS, we assess that before and after immobilizing. Again, don't forget to consider pain management in patients that may have isolated fractures who are in significant pain. They may even be able to walk on a fractured hip or pelvis with their pain. It's just that they don't have the their pain tolerance is so much better than perhaps their younger counterparts. If their environment is unsafe, then for us that would be a report with the Department of Human Services indicating a need for perhaps somebody to go into the home and do an assessment for fall risk. All right, toxicology. We have to consider toxicologic emergencies in geriatric patients because they may be on multiple prescription drugs, and these prescription drugs, depending on their liver and kidney function, may metabolize at a much slower rate and then build up, causing a toxic sort of situation. We've already identified that the older you get and the changes that occur as you age affect the pharmacokinetics of medications. It's important to identify what the patient is toxic to. by doing that, we may have an antidote that may reverse the causes of the toxicologic emergency. That requires you to get a thorough history, requires you to understand the different sort of toxidromes that are out there. But do understand in patients, drug interactions are much more common because they take multiple pills rather than a one or two. They may be on 5 or 6 different medications. If they're getting all their medications from the same pharmacy, drug interactions shouldn't be a big deal because all pharmacies now are required to have drug interaction software, as well as hospitals and inpatient units where patients are kept are required to have drug interaction software that identifies drugs that should not be used together. When you're dealing with a toxicologic emergency, it's your ABCs and then ACLS first, and then once you get those things stabilized, then consider the toxin or what was the toxin that caused the event. Patients with toxicologic emergencies need to be evaluated by a physician, preferably a toxicologist. Beta blockers are a common medication seen in toxicologic emergencies. They bind to the beta-adrenergic receptors throughout the body. They blunt the effects of the sympathetic or the fight or flight nervous system. So they decrease oxygen demand to the heart. They lower the blood pressure. They're used to treat hypertension and tachycardia. But again, if I'm an elder patient and I'm taking beta blockers twice a day and I forget whether I took my beta blockers, so I double up on them, and I do that multiple times during the week, and my liver and kidneys aren't working well, it's very easy for me to become toxic on the beta blockers. Beta blockers reduce myocardial oxygen demand with a coronary artery disease. But also with coronary artery disease, beta blockers may increase breathing difficulty and lead to bronchospasm. Some therapeutic doses. If you give an elder patient the normal dose of beta blockers that we would give other patients, again, they may become toxic, and a toxic presentation of beta blocker overdose is bradycardia, hypotension, lightheadedness, syncope, confusion. And beta blockers, remember, also may blunt the tachycardic response. So when you get into a situation where you need that rapid heart rate to maintain an adequate blood pressure, or you need that rapid heart rate, and we see a rapid heart rate as perhaps a sign of shock. If they're on, again, beta blockers and calcium channel blockers, their heart rate may not increase, and we may not see evidence of shock because the beta blocker may blunt that. Diuretics work at the level of the kidney to block the sodium and fluid reabsorption. They do this through a variety of methods. Probably the most common diuretic that everybody's familiar with is Lasix. Lasix works in the loop of Henle. It's a loop diuretic. It eliminates sodium out of the urine, and water is going to follow sodium. So that's one way that Lasix would help get rid of excess fluid in the body. Electrolyte abnormalities are more common when we're using diuretics, particularly loop diuretics, because they're non-potassium sparing. So because diuretics work by eliminating sodium, you may have low sodium levels because loop diuretics are non-potassium sparing. You create large amounts of urine, but within that urine are also large amounts of potassium. So it could lead to a cardiac dysrhythmia, but you'd be able to see that on a ECG strip with a tall P, teeked waves initially, where super high levels of potassium, you're going to see some sinusoidal waves, and very low levels of potassium, you're going to see perhaps U waves. But in any event, when you're looking at a patient on diuretics and they have an acute mental status change, you might be thinking of an electrolyte balance. Find out whether or not they're on digoxin, because diuretics and dig are harmful together. Digoxin is a heart medication that helps increase the strength of each heart contraction. It does slow conduction between the atrium and the ventricles. So it's a good drug to treat congestive failure or AFib or aflutter. It has a very narrow therapeutic window. In other words, the dose is very exact. And if you give the patient more than what they need or less than what they need, it's going to lead to problems. Even patients, again, depending on their kidney function and their liver function, will develop dig toxicity, even taking their normal daily doses. Dig is excreted through the kidneys, and if the kidneys aren't working well, then they may have trouble excreting dig, which could lead to dig toxicity. Toxicity signs include conduction disturbances and cardiac dysrhythmias, abdominal pain, nausea and vomiting, anorexia, and visual changes. Neuroleptics are antipsychotic medications. They block neurotransmitters and their receptors to the brain. They may pose anticholinergic effects like dry mouth, sedation, urinary retention, constipation, and hypotension. Benzodiazepines. Many patients are taking benzodiazepines, whether they be Valium, Versed, Ativan, for anxiety. They take them for insomnia or for agitation. The more sensitive they are to the medication, the smaller doses that should be used. And again, it's just a really good rule of thumb that if you're dealing with a patient over 70, particularly with not really good renal function, that we should cut the doses in half. The effects of benzodiazepines on patients include sedation, ataxia, confusion, and delirium. Non-steroidal anti-inflammatory drugs, or NSAIDs, are loaded with adverse side effects. Elderly patients who are taking non-steroidal anti-inflammatories are nearly 5 times as likely to die from a GI bleed. And renal failure, particularly from high doses of NSAIDs, is very common as well. Warfarin is the most common anticoagulant used. Warfarin, which is Coumadin, allows warfarin. Indications for giving warfarin include a blood clot, atrial fib, and the reason that you give atrial fib is certainly it's understood that if the atrium are fibrillating, they're not beating in an organized, coordinated fashion, and if they just quiver, then clots may form inside those atrium. And then if the atrium start to beat normally with normal strength, it'll flush those clots out into the head and into the lungs, causing pulmonary emboli and stroke. So Coumadin is often given for patients with a history of blood clots, patients with a history of atrial fib, a history of heart valve disease or a prosthetic valve, if they've had recent surgery or are bedridden, if they have a history of underlying clotting disorders, and if they have a history of deep vein thrombosis or pulmonary emboli. Warfarin hinders the normal physiologic clotting that stops the bleeding, so these patients have a tendency to bleed longer. Head injuries on patients on warfarin may cause an increase in the likelihood of an intracranial bleed, particularly if they fall and bump their head. GI bleeds are more likely to lose blood into the GI tract when a person's on warfarin. Narcotics are a highly effective form of analgesia in the elderly. You have the same adverse side effects as benzodiazepines with oversedation, constipation, confusion. I'm going to go back to that as far as the side effects that you see, but we also, have the ability that if they're on a narcotic painkiller, then we may be able to reverse those effects with Narcan. Nitrates act as vasodilators for all smooth muscle, not just the arteries of the heart, but all muscle. It improves coronary collateral circulation. It decreases preload, which decreases afterload, which decreases the heart's need to work hard. And by doing so, if the heart is in failure, like during a heart attack, if their blood pressure can support it, giving them nitrates is beneficial because the heart doesn't have to work near as hard as a pump. The myocardial oxygen demand is less, and they're able to oxygenate the tissue that they have. Nitrates are not analgesic medications. They don't take away the pain. If you give somebody nitroglycerin and their pain goes away, it's more than likely that the patient was suffering from like a coronary artery spasm. And when the artery spasm shut, the distal to that didn't get a blood supply, so it cramped and hurt. And then you give nitroglycerin, and it releases that spasm, and the vessel opens up, and now they get a good blood supply. The pain is going to go away, but it doesn't leave because nitro is an analgesic. It's contraindication in patients who have taken erectile dysfunction drugs, and you need to ask all patients that, not just men. Women take Viagra for migraines, for pulmonary hypertension, and to improve orgasm. Substance abuse, it often goes unrecognized because if an elder person is acting strange, or he's tired or sleepy, or speech is a little slurred, or the gait's a little off, they're often just looked upon as being old and not really understanding that they're under the influence of drugs or alcohol. Substance abuse may attribute to the severity of their dementia, and may include alcohol, prescription, and over-the-counter medications. Characteristics for the elder substance abuse patient: somebody who lives alone, is isolated, lacks social support, and you as a responder have adequate access to the patient. They're going to have a different presentation from your younger substance abusers as well. The signs of alcohol abuse are subtle: vague symptoms, multiple falls, anorexia, insomnia, confusion, mood swings, and hostility. Some risk factors that increase the risk of using other drugs and alcohol is depression, loss of employment, limited monetary resources, loneliness, and poor health. Environmental considerations: remember that the hypothalamus is the thermoregulator for the body, and as you get older and your hypothalamus doesn't work as it properly should, the elder patient may have difficulty regulating their body temperature, and as a result, they may not even realize that they're cold. They may not even realize that they are running a fever. we used to deal with a concept called urban hypothermia. And this is the I've fallen and I can't get up in a patient that's perhaps fallen in an apartment, has laid on the floor for a day or so, is not able to get up, and continue to get colder and colder as they lie there on the ground. It may be 70, 80 degrees in the room, but if they're elder, they have difficulty maintaining their body temperature, they don't eat enough to generate high body temperatures, and lying on that ground on that cold ground, if it's 80-degree floor, it's going to suck the temperature right out of that elder patient. So hypothermia is common in the elder patient, and when a person gets hypothermia, body temperature is less than 95 is the definition of hypothermia. Here they're saying when the core temperature drops below 89.6 that the patient is hypothermic. We're going to see shivering when it's less than 95. They get the umbles. They mumble, they grumble, they stumble, which typically sounds like an elder patient if all they're doing is mumbling, grumbling, and stumbling. But keep in mind, too, that their muscle mass is decreased, so shivering is less effective. They have less insulation, so they're less efficient at releasing catecholamines to also make those muscles shiver to generate heat. And some medications like beta blockers will also make you less or make you feel cold. Causes of hypothermia may also be related to a decrease in cardiac output, vascular disease, diabetes. Remember that when the body temperature drops below 91.4, then shivering stops. So if you have a patient who has an altered mental status and you're doing your assessment, note their skin color, temperature, and moisture. If it's cold and dry and they're not shivering, they're probably less than 91.4 degrees. Treatment is to remove them from the cold environment, get their wet clothing off, support their airway, breathing, and circulation, cover them in warm blankets. If we have the ability to administer warm saline or warm O2, that would help warm them up. Hot packs to parts of the body. We just can't put the hot packs directly on the skin because remember the skin of the elder patient may be thin and may have skin tears, may tear easy, those sort of things. So if we're going to use hot packs to prevent further heat loss in that elder patient, then put a wash rag or a towel or something on the body first before you place the hot pack on it. When the core temperature is greater than 38 degrees, greater than 101, the patient may sweat a little bit, but may not sweat much at all because remember their sweat glands don't function as well. They may have taken the following medications. Anticholinergics, antihistamines, narcotics, sedatives, diuretics, all blunt the normal response to dissipating heat and may lead to an increase in body temperature. Hyperthermia is divided into, heat cramps, heat exhaustion, heat stroke. We know that heat cramps are muscular cramps that are caused by electrolyte imbalances. So they may have been sweating a bit and they may have gotten rid of some of their electrolytes like sodium and potassium. They may be extremely thirsty. And in these cases, it's just important to replace the electrolytes that have lost. They've not lost so much fluid that they're in shock. and their temperature isn't so high that they're in heat stroke, but they have lost enough electrolytes that replacing them would help the cramps go away. Heat exhaustion is a more systemic effect, a more overall body effect. Now you've lost volume, you're mildly hypovolemic, you may be having heat cramps as well, and treatment would be very similar. Move them out of the hot environment, remove their clothing, cool them off, fan them down, kind of drop that blood pressure, or excuse me, drop that temperature. Heat stroke is defined when the body temperature goes above 40 degrees Celsius or goes above 104. It's going to have all the similar symptoms of heat exhaustion, but now with an altered mental status, and the skin is going to be very, very hot. This occurs as a result of not being able to dissipate heat at all or very little, and is directly related to humidity. When the humidity reaches 80 degrees, heat sweat by heat dissipation by evaporation of sweat ceases. So if you're in a really humid environment, you may still sweat a lot, but the ability for that sweat to evaporate and pull off heat with it is extremely limited. So temperature rises quickly. Trauma in the elderly is a significant cause of morbidity and mortality, particularly falls. Trauma affects the elder patient differently. Remember, with their decreased muscle mass and their osteoporosis, they're prone to more fractures. With their decrease in cardiac output, it inhibits their response to cardiovascular stress, so the ability to increase their heart rate and strength in order to maintain cardiac output may be an issue. If they have impaired kidney function, they may not be able to adjust to fluid shifts by retaining or eliminating fluid, trauma, particularly trauma to the chest, may lead to adult respiratory distress syndrome, which we'll talk more about in PHTLS. The number one cause of trauma in the elderly is falls. Then trauma also can occur from assault or abuse or burns. Survey the scene for signs of abuse. And the signs of abuse on elder patients are the same as children. Bruises in multiple stages of healing in parts of the body that don't bruise. If they are with a dependent adult, note how the dependent adult acts around that elder patient. If they've suffered significant trauma, as outlined by your out-of-hospital triage trauma destination decision protocol, then you're going to implement rapid transport. Shock may be very difficult to identify in the elder patient, particularly, again, if they're on beta blockers or calcium channel blockers, because we won't see that increase in the heart rate. We may not see the pallor and those sort of things that commonly are associated with shock. Hypertension may remain quite normal, even with blood loss volume. And fractures may be present without any significant pain. So they may be walking on a leg or using an arm or one of those things and not even realize that the bone is fractured. Treatment for trauma, airway management is going to be difficult. If they have dentures, you're going to have to remove those dentures. If they're posing a problem with getting a good seal and delivering an adequate ventilation, you'd give them oxygen, you'd start an IV, but hold back fluids unless there's evidence of significant blood loss, and then in that case you want to give fluids, but only to get pressures around 90. Monitor them for the development of pulmonary edema, particularly if you're given fluids. Hook them up to a cardiac monitor looking for arrhythmias that might be associated with tamponade. Orthopedic injuries are common in the elder patients, again, because of osteoporosis and decreased muscle mass. Muscle mass is going to increase the risk of hip fractures, and the hip fracture is the most common type of injury in elder patients. They just need to be immobilized and transported. Splinting may be necessary. It may require bulky paddings to fill in the voids when you're using splints. Patients with severe kyphosis, a nice curvature of the spine, should have a lot of adequate padding under their head or shoulders, um, uh, because they're almost sitting upright with severe kyphosis when you lay them flat. Administer medications for pain per protocol as long as their vital signs are stable. Burns have a higher mortality rate in elderly, as do trauma, because elder patients just don't tolerate trauma as well. Patients may have more pre-existing illnesses that go along with the burn. They may have fluid retention. Not fluid retention. Yeah, you can tell it's getting late. I'm having difficulty seeing the word on the screen. Fluid resuscitation. And again, we know that when a patient has a burn, that they're going to lose plasma, and that we should replace volume. How much volume is extremely controversial. You know, if their lungs are dry, then we're not hearing any wet sounds. They could handle a fluid bolus of 500 mils. There's the Parkland formula to determine the amount of fluid for resuscitation. There's the Iowa EMS protocol, which is a 500 mil bolus. There's the United States Army's method of the rule of 10, where you take their total body surface area as long as they're under 80 kilograms and take that times 10. So if they had a 45% body surface area burn, you give them a 450 mil fluid bolus. And whatever method we use, it should be simple and easy to follow. And the preferred fluid of choice is going to be lactated ringers. An LR is preferred because of an extremely rare condition that may happen when you're giving large amounts of saline over a short period of time. The patient may develop a hyperchloremic acidosis from all the chlorine and the sodium chloride that you're giving them. So lactated ringers is the fluid of choice for burns, but the small amount of saline that we would give them doesn't hurt the patient and wouldn't constitute us carrying LR just for a burn. Treatment, ABCs, IV fluids again to prevent renal failure and tissue breakdown, monitor their urine output. Head injuries can be difficult to assess or recognize, particularly in a patient that has had previous dementia. Head injuries, particularly subarachnoid hemorrhages, are common in the elderly because as we age, our brain atrophies or shrinks. And as it shrinks, it occupies less space inside the cranial vault, so it's allowed to move around there more. And in moving around more, it's at risk of slamming onto the front of the skull, causing a coup contra coup injury where an elder patient may fall and smack the back of their head. The brain slams against the back of the skull, causing damage to the vessels there, but in doing so, pulls and stretches the vessels on the front of the brain to where they themselves may rupture as well. So you have an injury both front and back. The blood must accumulate inside the head before causing any sort of symptoms. So depending upon how fast the bleed occurs determines when you're going to see the symptoms. They can bleed very, very slow to where it might be a month or two before you even see signs or symptoms from a seemingly minor head injury. You want to aggressively treat head injuries in all patients, rapid transport to a neurosurgeon. Just remember that even minor trauma, particularly in patients on blood thinners, can cause intracranial bleeding. Be alert for previous trauma, previous subdural hemorrhages, and again, those subdural hemorrhages can accumulate over weeks or even months. All right, so that concludes Geriatric Part II. And if you have any questions, you know how to get a hold of me. We'll move on to the next chapter in our saga that should take us through our special population and get us primed and ready for our trauma section. So I'll talk to you soon.